Welcome to this week's Echo Diabetes in the Time of COVID-19 webinar session. I'm Dr. Nick Kutchers. I'm Program Director of this program. I'm a pediatric endocrinologist at Stanford University. Good morning, good afternoon, aloha to all those joining. I want to take this time to acknowledge our sponsors. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that made this program possible. As a reminder, our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty care. Even before the COVID pandemic, outcomes for patients with diabetes were suboptimal. Despite more than 25 years under recommendations of tight glycemic control for type 1 and type 2 diabetes, the majority of individuals in the United States have been unable to achieve these goals. Data from over 190 million people enrolled in health plans that report HEDIS results to the National Committee on Quality Assurance in the U.S. illustrates system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C values at target, or less than 7%. Even more concerning, 30 to 40% of patients had A1C values greater than 9%. We must recognize that these outcomes do not reflect patient noncompliance, but rather this is system failure. Minimizing hyperglycemia is paramount to reducing diabetes patient risk and vulnerability to increased infections and complications, and including during the time of COVID. Now is an opportune time to overcome therapeutic inertia and make meaningful system changes so that patients are able to achieve glycemic targets. Here at Stanford, we're partnering with Project Echo and other sites across the United States on the series. Project Echo is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide providers with education, case-based learning, and expertise that they need to treat patients within their own community. Our presentation agenda will be a lecture followed by a case presentation, and we will address some of the pre-submitted questions our audience members submitted during registration. We will have a short Q&A session after the lecture and after the case presentation. For those of you who have not participated in an ECHO session, please submit any clarifying questions and or recommendations in the Q&A box for the case. Please use the Q&A feature in Zoom to submit questions specific to the topic or presentation. The chat box can be used for communication amongst our attendees and sharing resources amongst the community. We will try our best to address all your questions submitted through registration and chat. However, if we are unable to get your question today, please register for a future session and submit your questions. Last week, we were able to address 100 live questions, and we look forward to continuing to address these. This webinar is being recorded, and this lecture portion of this webinar will be available in a few weeks on our website. The case presentation from today will not be included on the on-demand webinar. Our web development team is working to build a resource library on our COVID-19 website where session materials may be found. After the webinar ends, you will be emailed an evaluation that will enable you to claim continuing education credits. Please note that none of our faculty have any relevant financial relationships with commercial interests to disclose. As a reminder, if you would like to submit a case presentation for a future webinar, please visit our website. You can find the URL listed here, and we'll also type it into the chat box so you can copy and paste. You should have received an email confirmation after registering for each session, which also has this link to submit a case. We have an exciting series yet to come with excellent and relevant topics. As a reminder, you and other learners are welcome to drop in for any of these one sessions, and you need to register independently for each session. We are fortunate to have a national faculty team of over 12 ECHO programs and organizations around the country. I would now like to introduce them, and I'm going to stop sharing my screen and introduce the panelists. I'm going to start with California and Stanford University. Once again, I'm Dr. Nick Cuttress, pediatric endocrinologist and program director of ECHO in the diabetes time of COVID. Linda?
Hi, I'm Linda Baird with Stanford as well, and I'm the director of education for the program.
Marissa?
Hi, I'm Marissa Town at Stanford in California. I'm a registered nurse diabetes educator and the program manager.
Christine?
Hi, I'm Christine, program coordinator.
And moving on to our faculty, Marina Bassina.
Marina Bassina, adult endocrinology at Stanford.
And Corey?
Hi there, Corey Hood from Stanford University, professor and staff psychologist here.
And Magdalena?
Hi, I'm Magdalena Ford, a family nurse practitioner in adult endocrinology at Stanford.
And also California, Jay?
Hi everybody, Jay Schubrook, primary care diabetologist at Touro University, California. Glad to see you.
And also from California, Kelly?
Kelly Close. I'm the founder of diaTribe.org, and I'm a patient representative here. I've had diabetes almost 35 years.
And moving to the East Coast, Eleni?
Hi, I'm Eleni Sheehan. I'm a family nurse practitioner and certified diabetes educator from the University of Florida, and I've lived with type 1 diabetes for 39 years.
And moving back west, Dan in Hawaii.
Hello, I'm Dan Saltman. I'm a primary care internist and an associate clinical professor at the University of Hawaii Department of Medicine.
And to Iowa, Dave.
Hi, I'm Dave Faldmo. I'm a family practice physician assistant and help run our endocrinology ECHO in cooperation with University of Nebraska, Omaha.
And Maine, Erwin.
I'm Erwin Brodsky. I'm an adult endocrinologist at the Endocrinology and Diabetes Center at Maine Medical Center and an adjunct scientist at Maine Medical Center's Research Institute.
And Massachusetts, Samar.
Hi everyone, I'm Samar Havida. I'm an adult endocrinologist here at the Jelston Diabetes Center in Boston.
And to Nebraska, Leslie.
Hi, I'm Leslie Island. I'm an adult endocrinologist at the University of Nebraska in Omaha, and I've had type 1 diabetes for 12 years.
And to New Jersey, Mary.
Hi everyone, I'm Mary Bridgman. I'm a clinical professor at the Ernest Mario School of Pharmacy at Rutgers University. I'm a clinical pharmacist at Robert Wood Johnson University Hospital, and I'm representing our complex endo echo from Robert Wood Johnson Medical School.
And to the ECHO Institute in New Mexico, Matt.
Hey, Matt Bichonville. I'm an adult endocrinologist here at University of New Mexico. Good to see you all.
And New York, Marissa.
Hi, I'm Marissa Desmond. I'm an adult endocrinologist at SUNY Upstate in Syracuse, New York.
And to Washington, D.C., Nicole.
Hello, yes, I'm Nicole Earhart. I'm an adult endocrinologist at George Washington University.
And also in D.C., Rohit.
Hi everyone, this is Rohit Jain at George Washington University. I'm an adult endocrinologist there too.
Great, I think I got everyone. Now it's my pleasure to introduce our speaker for today, Kelly Close. Kelly chairs the diaTribe Foundation, a nonprofit established in 2013 to improve the lives of people with diabetes and prediabetes and to advocate for action. Kelly's passion for the field comes from her extensive professional work, as well as from her personal experience having had diabetes for nearly 35 years. She's the founder of diaTribe.org, begun in 2006 as an educational resource for people with diabetes. diaTribe.org's free educational material mailer goes to nearly 250,000 people every week and has over 2 million people visited the website last year. Kelly has a BA from Amherst College and an MBA from Harvard Business School. Kelly's an associate editor of Clinical Diabetes, a journal focused on diabetes for primary care physicians, published quarterly by the American Diabetes Association. She was a founding board member of the Institute for Responsible Nutrition, led by University of California's San Francisco, Dr. Robert Lustig. Kelly, thanks so much for taking the time to provide the slides and didactic today. And before we get going with her presentation, we're going to do a brief poll. And if you all can respond to the questions, to the polling. The first question, I spend my time as either a primary care provider, endocrinologist, educator, student. The majority of patients I serve have type 2 diabetes, type 1 diabetes, prediabetes. Do you use CGM with any of your patients? Yes, real-time. Yes, real-time plus professional. No, I'm not familiar with professional CGM. I'm not familiar with real-time CGM. And we'll give it another 15 seconds for people to respond. All right, we're over 60%. Can we get to 75%? Great. All right, with that, Kelly, I'm going to let you take over. And we're going to share your slides and just to let us know about advancing.
Yeah, terrific. And gosh, thank you so much for inviting me to be here and share some patient perspectives with you. Thank you to ECHO for organizing this. This is phenomenally powerful, and to be able to get to spend some time with you is a really big deal. So my name is Kelly Close, as Nick said. Thank you so much for that generous introduction. I'm really driven by making the world smarter about diabetes, all to the end of improving patient outcomes. I've had diabetes for almost 35 years, and today, I'm really speaking to you as a patient advocate, a mom of 3, mostly teenagers, a partner and a leader of organizations based in San Francisco that really care about moving the needle on diabetes through advocacy and education. And first, I just want to thank all of you, doctors and educators and students and others who are here. So on top of being a healthcare professional or a healthcare professional in training, you're all advocating for patients in so many ways. And, I know and I appreciate that you're doing the heavy lifting. And I appreciate that you chose this. I'm guessing you don't get thanked often enough. I'm curious, I don't know if maybe you could raise your hands or say in chat, but when was the last time your family thanked you for what you were doing? Because please thank them from me. I like to thank them too. I know how much they're doing to enable what you're going to do every day. And, I remember when I was young, I didn't ever thank my doctors or educators. And I didn't thank my parents. They passed away many years ago now, but I was just so busy having diabetes. And, maybe that's why you don't get thanked as much as you should. But the work that you are doing is incredible. And again, that you chose it, I'm so grateful. And it's going, I hope, with all of the policy changes that are before us, some of which I want to talk about today, I hope it can get easier. So I want to go to the next slide. And just want to say here, COVID-19 has obviously just changed the way that many of us, that all of us are living, really. And actually, you know what? I think I might even be on the next slide. If you can move to the next one. Yeah, I don't have any financial disclosures. Yeah, this one. So, you know, I think it's, everyone obviously is experiencing COVID-19 differently. It's really variable. And I'm guessing that more of your patients and more of you have way more rather than less stress, you know. But a tiny little thing is that I think all of your patients, whatever else, and I know there are a lot of things that are compounding all of our experiences, but whatever else, probably everybody has at least a few fewer distractions. And even if it's in the state of so much more stress, which obviously this pandemic, I guess we're almost on day 90, has affected all of us, and my heart goes out to you if it has affected you or your family personally. And I would try to just remind patients that this could be a moment, you know, these could be moments where they're working on their diabetes a little bit more because of some things that are happening out there on the policy front that might make things easier, and because of easier tools. You know, amidst, you know, there's chaos, there's uncertainty, there's unpredictability, there's ambiguity. Diabetes already feels like a roller coaster to so many of us. And to some patients who have gotten luckier and who have benefited from more recent tools, whether those are cardioprotective medicines, whether those are, you know, renal protective medicines. And I know access has been hard with a lot of these, but some of them it's getting easier, you know, whether or not they may have been able to benefit from CGM. That is amazing. And I don't know if you might raise your hands if you use CGM regularly. That would be great for me to know. But while there's a spectrum of difficulty, you know, everybody is struggling and adapting to change in some way. There are some things happening right now that are making things easier. CMS, you know, the people that run Medicare have dropped the barriers to getting CGM some. And I would also love to know if you have stories about how this is still really hard, please let us know at diatribe.org. Our lead story right now is about how they don't have to do all those finger sticks to get CGM anymore. We're not saying everyone should have real-time CGM all the time. We know that there are still lots of problems with affordability. And we know that everyone getting the chance to use professional CGM at least helps patients understand where they are. And for us as patients, like when we know where we are, at least then we can work a little bit more easily on where we want to go. Today, I just want to talk about the importance of your partnership and your role as a healthcare provider to help people living with diabetes make some key changes that are especially possible at this moment. And I would love to go to the next slide, if we can. So I know a bunch of you have seen slides like this before. This is all about, even though many individuals have gotten to improve their diabetes, not enough has changed at the population level. And we all know, you know, that's largely due to access problems that are broad and vicious, you know, housing insecurity, food insecurity, things that all of you are not able to work on all of the time. And I also feel that this is a moment in time, COVID-19, we're all going to look back at this and say, like, what came out of this? You know, there's so many patients that are marginalized, that are underserved, and there are opportunities to help them in major ways with, again, new tools. And you can have a huge role in that. And I really think that, you know, kind of the here and now of where patients are, a lot of this can change. There have been some amazing advancements, and a lot of patients have been left out. Tracy Brown, who's CEO of the ADA, was at the White House yesterday on, you know, a live stream talking with Donald Trump and with Seema Verma, who heads HHS. This is, whatever else we want to say, we have never had diabetes at this level of visibility. Insulin now becoming for everyone on Medicare available for $35 a month. These are great changes, and there's a lot more to do because, of course, it's not just affordability, but it is also for people to know, you know, how much to take and when to take and all of that. And you can do so much more with patients through using some of the tools that I'm going to talk about, because we now know there are tools for primary prevention. There are tools like GLP-1 that's available for primary prevention that are available for $10 a month to everyone, at least for the next year. I don't know always how all of these programs work, but there are ways to help your patients. There are ways to help your patients be able to access more. And, you know, I think this is about like helping people realize, you know, what they deserve. And I think it starts with technology. It doesn't have to be CGM. Again, professional CGM, I think, is a really good place at least to start. But BGM is way cheaper now, being able to help connect patients to the cloud. This is going to take way more of your time at the beginning. I know you're spending a lot of time on telehealth and helping patients prepare, but this is what is going to help patients do much better in the long run, working on their diabetes management themselves. So I'm just here to kind of name, you know, what's missing from some clinic rooms, from some patient healthcare provider conversations, and that's the measurement of time in range and the conversations that it can lead to. The measurement that kind of tracks our lived experience as patients, and the measurement that can make true felt partnership between healthcare providers and patients even more of a reality. And if we can go to the next slide, please. Yeah, you guys have seen this too. This is kind of what this means, is like, I want to live next door to you. You know, like, I want to live next door to you. I want to hang out with you. I want to see you way more as a patient, and I don't get to, and the system is not going to enable that. You know, we get to spend like 15 minutes a year to maybe an hour or two a year with you, and the conversations though that happen in the clinic or across the computer, the questions that you ask and the way that you listen to us can help us set goals and really reframe success through the different foundational decisions that you help us make. And if we could go to the next slide, this just shows our sister organization at diaTribe.org. That's a organization called ZQ&A. They surveyed people living with diabetes, and they asked them what they most wanted to tell their healthcare providers. And we're just going to take a half a moment here for you to read these. But, you know, I know you can see that feel insecure about the complexity of their feelings, management with their healthcare providers, not feeling like they're learning enough maybe, or just confused. And we can go to the next slide when you're ready. But, you know, and they want to hear good job, you know, when they see some success. And when you use time in range, you can do that. It doesn't have to be about this golden number of 7 or even 8 for an A1C, because you can recognize changes that are really small. And again, you know, the rest of my talk is just about like things that work. And I just want to introduce this by saying, I mean, there are not very many healthcare areas that have seen the incredible scientific progress and the incredible progress on the technology front that ours has in diabetes. And I don't know if you all know about Diabetes Wise. This is something that Professor Corey Hood and a lot of his other colleagues at Stanford have made. I know we all hear that the technology is confusing. And of course it's confusing. Life is pretty confusing. You know, I mean, diabetes is confusing, but there are so many ways in which there are better tools and better kinds of education. Echo is one of them. I'm in awe of all of you. So I just want to say that, because I think CGM can unlock so much. And again, it doesn't have to be 24/7. It can be professional CGM, but it can unlock, you know, whether somebody might be on a sulfonylurea and they should be on insulin, you know, and maybe they're a new patient to you. Anyone who is at risk of heart disease, you know, really should be on a GLP-1 if they're type 2 only. There's now one of them that is approved for primary prevention. And we're, as patients, we're not used to, and type 1s can't do this at this point, but we're not used to having medicine that prevents stuff. Like, we're used to having medicine to control our blood glucose. Maybe traditionally that medicine also makes us gain weight or puts us into hypoglycemia. We don't have like a great relationship, a lot of patients, with medicine, but there's so many better ones now, and the applications have gotten so much easier. And this is what CGM can help get you to. And again, starting by helping them doing more learning is fantastic. The frame here also that I want to share is from a really cool author called Dan Pink. He works on the world of work, and maybe you could say in chat if you've heard of him. Dan Pink's tools, you know, they're not designed specifically for diabetes, but they show a bunch of success in other fields. So I'm going to just try to ride his coattails of success quickly. And just to say, like, this is kind of about moving beyond simple carrots and sticks. He suggests in his highly regarded book, Drive, that we focus on 3 core principles to motivate people. And you have so much room to motivate people. We all worship you, and we're a little scared of you, you know, in many cases. But I think if you can maybe think about some of these things, and I would love to know in chat what you think about it. But like autonomy, I mean, and this is not about saying the words autonomy or mastery your purpose to your patients. Some of them might be interested, but it's really about like, how do we feel? And it kind of is about how do you make us feel? We just want to be more successful from whatever base we're starting from. So, you know, autonomy, that's all about the need to direct your own life and work, and mastery is just about wanting to improve, again, from any base. And of course, we all want to do that. Look at all of you for inventing time, basically, to be here. You know, and just purpose, working towards something larger, you know, zooming out to a bigger purpose. And I'm going to ask to move to the next slide, but just that one piece on purpose, I mean, I know what an amazing set of changes you all can make in diabetes, again, because of all of the technological progress and scientific progress. So the next slide is just about 42 factors that I'm going to ask to move to one more slide. Actually, I don't know that we have this. Oh yeah, we do. So these are actually, this is something that the brilliant Adam Brown put together at diaTribe.org. He wrote an amazing book called Bright Spots and Landmines. It's free online. But this is all about the different things that affect our diabetes. And a lot of it is about complexity of how it feels to be a patient. But if you track, you know, how these 42 factors affect blood sugar, just even looking at them, that kind of instills a sense of autonomy in many people with diabetes, just even looking at this chart, because we now know A1C is not just like us failing when we don't get the right number. There's a bunch of stuff going on. There's also, I don't know how many patients actually know this. I'm not even sure how many healthcare providers have really focused on it because the research is on the newer side. But there are a lot of limitations to A1C, you know, including not being an accurate glycemic measure for many populations because of differences in red blood cell lifespan. Is that crazy? So there's already, you know, if you're at the lower ends of the socioeconomic spectrum, already if you're part of minority communities that are really experiencing hardship, the fact that like A1C might be less relevant to you, that's not even that well known, but it's another reason why we really believe in time and range, and why we don't think that A1C kind of explains the constant picture of our lived experiences with diabetes. And okay, if we can go to the next slide, that would be awesome. Yeah, so a bunch of you also may have seen this before. This is kind of just about like, you can have a 7% A1C. I think being 100% in range, that's pretty aspirational. But you know, you can have low blood sugar so much of the time. And I lived for many years hypoglycemic almost all the time, because I was just trying to, you know, that's kind of what happens when you live close to the edge, when you're taking NPH. Oh my gosh. Hi, John. Sorry about that. And so like, you're trying to do a good job, and then you're ending up more in hypoglycemia, and then you're ending up more in hyperglycemia. And I know all of you who obviously work with patients taking insulin experience know the differences with this. But I think when you let patients kind of understand how time and range is working, or when you help enable that, that can just be so incredibly powerful. Time and range really gives us a better sense of where we are today. And then we can figure out again where we want to go, and we can figure it out with you. And that's so valuable. Time and range is really the level at which people experience their A1C and relive those 3-month averages minute by minute. Am I too high? I might need to eat differently. Maybe I could take a walk around the block. Maybe I need to take more insulin. Maybe I need to talk to you guys about how insulin should be at a bit higher dose. Am I too low? probably need to eat or even take glucagon. And every single person with diabetes who's on insulin, by the way, or sulfonylurea should have next generation glucagon. It works so much better, and we all want to stay out of the emergency room. So I hope that you can convey that to your patients. But anyway, all of that sort of stuff, and we can go to the next slide, but all of that stuff kind of helps me think about autonomy. And this is a really, I think it's a really big cultural shift. I've really been influenced by one of the amazing women in my group, Divya Gopisetti, who is going off to medical school at Stanford. I've gotten to work with her for 2 years, and she's has a sister with diabetes. She says, like, this is a big cultural shift. And I absolutely agree with her, you know, and I love their generation. They're smarter than any generation that I've seen or studied. We all need to support young people in training, as I know all of you probably already do. But anyway, she said before COVID-19, you know, that time in range was a cultural shift. Again, not just about CGM, but it's BGM too, and how to use it. And that is the standard of care for people in systems that have enabled healthcare providers to be able to learn about time in range, know about it, and use it successfully. And with so many tools that can help us now measure time in range, or even results in range, and that's what it is if you're using blood glucose monitoring primarily, that's transformed, and it is transforming the way that healthcare providers can work in partnership with their patients. So I'd love to go to the next slide. Thank you. So time in range really gives people with diabetes the opportunity to reflect on their successful moments and to build autonomy from them rather than feeling out of control or even maybe victimized by some of these seemingly random factors. In another survey by DQ&A with thousands of patients, we saw that time in range was the factor that had the biggest impact on patients' lives. And you can see that if you'd like to see that data at diatribe.org/TIR. And if we could go to the next slide. Thank you. FNIR, is that amazing? FNIR, doesn't it sound glorious? So we just want to be moving toward that. And we know that it is possible to get closer to it. And I love that. I think that came out of IDC. But I find this like very aspirational, even if getting to absolutely flat is hard. And again, you know, even if people are only looking at this once a year through professional CGM, that's better than nothing. If we could go to the next slide. Yeah, and this is how you get to time in range if your patients are using BGM, which most people are. You know, there's, I think it's 1 million patients in the United States who are using CGM right now out of 24 million of us who have diabetes. I do want to make sure that you guys know, because this is all new, you know, CMS is making it more possible. CMS said, you know, 2016 that everyone on insulin on Medicare should get CGM. And we know that there have been many hassles to actually making that happen, and some of those hassles are going down. And so there's 3.3 million people on Medicare who take insulin. There's probably about 11 million people in all on who have diabetes. It seems like probably more people would benefit from insulin, maybe if it's just, you know, a small amount of basal insulin, and that as of yesterday is getting easier to get. And so, you know, we don't have to be scared of that. And there are so many insulins now also that are just not associated with severe hypoglycemia or hypoglycemia, and even cause less of it, and they cause weight loss and all of that. And if you actually take insulin in any amount, you actually can qualify for CGM. So I hope that more people will be able to get both. If we can go to the next slide. I mean, that's what's going to enable more success. I mean, just helping us with the foundational stuff of being able to be on the right therapy is really, really powerful. So we're going to keep going with the slides here. There's an amazing behavioral guru at Stanford. His name is BJ Fogg, and really all about his work can kind of be summarized in help people do what they want to do and help people feel successful. So he has a new book out called Tiny Habits. I recommend it for you guys to read, maybe if your patients like that sort of stuff, but they don't have to read it to know and to be able to get that, you know, you can help them understand. Stop judging yourself. And that is so hard. Like we do that all the time as patients. I remember in business school, I was dating someone new and I was trying to explain to him, I might pass out, but I'm sure it won't happen. but just in case it does, you know, and he was listening to this. I was basically trying to hide my diabetes, but to tell him about it too. And he just said, you know, wow, you must feel like your body has totally betrayed you. And I said, no, I feel like a total failure every day. You know, and just like the mindset that we have as patients, even if we're trying to make ourselves kind of look more together than when we're with you, just to know that many of us have that, you know, and just breaking the things down into tiny behaviors. And you can do that. If you see 20% time in range, hey, let's like move toward 25% time in range. You know, the whole embrace mistakes at this moment feels a little hard, but it's so true. That is how we learn. And I would love to go to the next slide. And just to say, you know, this makes so, I mean, like 8.9% for an A1C, what does that even mean, you know? Or even 6.7% or 14%. I mean, time in range is like, I get it, you know, I like 20% of my time is in range. So I have a big opportunity to get better. And if I can move from one appointment to another with you and get to 25% time in range, or maybe it's 50 to 55, or maybe it is 70 to 75. 70 is where is kind of the target. For people with type 1 and type 2, it's a little bit, that's 70 to 180. It's a little tighter range for people who are pregnant. But this to me is amazing. It can help me feel successful as a patient. And I would love to go to the next slide. So this is just all about, you know, all about purpose, right? So we talked about this a little bit. Purpose is the motivation to work towards something larger, to zoom out to a bigger picture. And I'd love to go to the next slide. Again, I went through a lot of this before about, I know you know that I love time and range. It's my favorite tool. Right now, again, during COVID-19, it is up to us this minute. Right now, CMS has dropped the guideline, dropped a lot of the barriers. And so it's up to us to get the word out to patients that they have a better chance of getting CGM now. And yes, this rule might disappear, but if they already have it, then, you know, they can get sensors and so forth after that. And we're trying at diaTribe to do as much work as possible on access to all of that. But the fact that they have done their part, the government has significantly loosened requirements. No longer are in-person visits, lab tests, or finger stick documentation required. And my ask to you is that you leverage this moment. Much more of this is also available to get through pharmacy benefits. And again, that's our lead story at diaTribe.org right now. And if we can go to the next slide. This is just about, you know, everybody wants to live better lives. And this is just showing like you can do this through BGM. It's just results in range and helping the patients upload the data and all of that. I know it is not that easy, but to help patients with that is great. And if we can go to the next slide. Yeah, I mean, everybody here can be advocates. I know you are already doing this. You know, it's part of the human experience to want to live healthier, happier lives. Time and range is a piece that will help us, and I get it. For all your patients who are worried about food insecurity, who have 3 jobs and, you know, very unstable family lives, obviously it's not going to be a panacea, but it is a more accurate and helpful coach giving us feedback along the way and can help you. And for patients to really understand that it can help short-term and long-term is amazing. And that's one of the ways that you can be an advocate. I know that you're being an advocate in many, many, many other ways. You know, everybody deserves to benefit from scientific strides. And you may feel like in your appointments, you don't even get to that, because when you ask, how are you? You know, the other things that you need to help patients with, or the other things that you're doing on the behavioral front, et cetera, are also obviously hugely important. But the foundational stuff, like helping them understand food and helping them understand their therapy is so foundational. And time and range is really a key to enabling that. And that's nationally, that's globally, that's locally. If we can go to the next slide. I would love if you would tell your patients about diaTribe.org. They can go to our website and learn a lot about just about different things that we think will help supplement everything that you're doing as doctors. And it's a privilege, really. We can go to the next slide, just that you would spend these moments with us. And for patients who want to learn more about what you're saying, about COVID and all that sort of stuff. We've talked to many doctors. They can go to, I think it's one more slide from now, they can go to diatribe.org/COVID-19. They can look at some of those resources. And the next slide goes through, the next slide, that's just a little bit about Adam's book. And just to say thank you so much for this opportunity to speak with all of you.
Thank you so much, Kelly. And we're going to open it up for questions. If you don't mind typing a question specific to Kelly. And there's already been 35 questions that have been answered. If you go to your Q&A box, you can see responses there. Great questions coming in. We don't have time to summarize each of them. We have a question coming up on pregnancy, which we'll address in our upcoming case presentation. Great questions about CGM and how to get patients on CGM, and this is a great warm-up for next week's session where we're going to dive deeper into the different types of CGM and look at more on prescribing it. So we're going to move to questions. Let's see. And there's also been some questions coming into particular patients that you all might be managing. As a reminder, on our website, you can submit a case for a case presentation. For those of you new to an echo session, that's really the core of what we try to do. And so if you have a particular case, we would love to get to that, and please complete the form, and we'd be happy to respond. Marissa, did you see any other questions come in for Kelly?
I don't know. Do any of our Q&A respondents have anything they feel we should cover before we move on to the case presentation? I think most of them we tried to type in, and again, we apologize for not being able to answer everybody's questions right away, and we appreciate everybody submitting their questions in the Q&A.
And there was a question that came in earlier about copays and insulin assistance, of noting it's not that black and white, and you're absolutely correct in terms of figuring out the systems of if you have private insurance versus public insurance. If you have public insurance, then the copay assistance don't work. You have to rely on your F2HC pharmacy benefits. And there's only certain amounts of different types of medications on there. Some are more expensive than others. And this is really complex stuff. And there's questions coming in about why can't PharmD's notes be acceptable for CGM? Excellent point. Mary, if you're more than welcome to respond to this, but lots of this stuff just doesn't make sense. And we need to continue to advocate and submit these prescriptions and show that we're trying to get this through and not give up.
Yeah, I think with the PharmD question, it's a big question of pharmacists and provider status, that we're really not recognized by Medicare as providers. So a huge opportunity, and we know our national pharmacy organizations are working to advocate for us, but such a tremendous opportunity for us to advocate on behalf of our patients for this opportunity as well.
And we're going to move now to pre-submitted questions. We have about 7 minutes for them, but as a reminder, as you register for the webinar, you can submit some questions. And the first one's a great, and while we address this, our faculty will continue to try to answer your questions that you've submitted live right now. And this question's a great follow-up to last week's case for a patient who was on high doses of Premixed 70/30 insulin. And so the question was, what is the maximum dose of Premixed 70/30 insulin that can be given to a patient?
Sure, Nick, I can take that one on. So, again, this is a great question, and I think everyone on the panel would probably agree that it's a little bit complicated and certainly nuanced. I think we're all familiar with the mantra that there's really no maximum dose when it comes to insulin. However, when I get this question, I'm usually thinking or feeling like there's a little bit more to it, perhaps, or just, again, more to the story. We know severe insulin resistance is defined as greater than 2 units of insulin per kilogram per day, or a daily insulin dose of more than 200 units per day. And certainly this isn't uncommon given the prevalence of obesity. And it's important to remember that, sort of these numbers, because there's really no consensus guideline or statement for how to best treat patients who have severe insulin resistance. Again, numbers of factors, as I've depicted on the slide, that can contribute to insulin resistance. And I think it's important as part of a therapeutic evaluation to look at some of these factors that might potentially be reversible or that we can address. And I think we brought it up in this week's case, we brought it up last week, but things like injection technique, use of expired insulins, or making sure patients are using their products properly, addressing lipohypertrophy, for example, use of concomitant medications, and so forth. I think that is an important step in evaluation here. And Nick, we can go to the next slide. It's worth revisiting the various concerns that exist for using high-dose insulin. I think the big concerns have to do with hypoglycemia, with dosing errors. As a pharmacist, I always get a little bit uptight when we're using U500 just to make sure we've got proper protocols and everyone is in line with the plan, what we're talking about. And then also issues related to absorption. We do know that insulin absorption, one of the factors that can influence it is the volume, in fact, that we're injecting. Again, other major concerns with just using high doses of insulin as part of a therapeutic care plan, when we've got a patient with insulin resistance on insulin with an uncontrolled A1C, we end up increasing the insulin dose, which may contribute further to weight gain and really exacerbate insulin resistance. So it sort of becomes this vicious cycle. And oftentimes I'm thinking as part of a care plan about paradigm shift and about different types of therapies that can perhaps interrupt this cycle if our patients can afford and access them. So to kind of get at the root of the question, my last slide, so what about these maximum insulin doses? And I think this goes for 70-30, but also for several of our other products. There is data to suggest that the administration of a single dose of insulin of more than 1 milliliter in volume contributes to pain and altered insulin absorption. When it comes to maximum insulin dose recommendations for volume, there's really no strong evidence. It's really expert opinion at best. We know that insulin absorption is influenced by a lot of physiologic factors: body temperature, blood flow, site of injection. I think really the bottom line when it comes down to it, we have to think practically about insulin delivery devices. Our syringes maximally holding 100 units, our pens delivering 60 to 80 units per injection, and really beginning to consider splitting doses when we're talking about more than 50 to 90 units at a single injection site. I like to look at our patients. I like to look at my patients and how they're responding and think about if this is necessary. Recommending splitting doses in order to facilitate absorption. So again, there's no magic number. Again, it's expert opinion at best. There's no strong evidence for either of these factors. We know splitting injection means a second dose or a second needle stick, which is not pleasant either. So that's when we have to start thinking about concentrated preparations, maximizing metformin and other therapies as well.
Thank you so much, Mary. And we're going to move on to the last question, and we might need to combine these two or come back to the third. Rayhan was going to address this. What are some reasonable COVID-19 precautions in people with diabetes, and what should someone with diabetes do if they are infected?
Perfect, Nick. So this is a shared responsibility for preventing infections. Again, this is expert opinion from the CDC, but wash hands with soap and water for more than 20 seconds or use a hand sanitizer with greater than 60% alcohol. You want to avoid touching eyes, nose, or mouth with unwashed hands. Stay at least 6 feet from others and do not gather in groups. Wear a face mask with a few exceptions. Cover the coughs and sneezes. Clean and disinfect frequently touched surfaces, and watch for any symptoms. And next slide, Nick. For diabetes in particular, we want to continue current treatment, closely monitor blood sugar, keep at least a 2-week supply of medications and anything else one needs. Do not delay getting emergency care. as sometimes when we tell people, well, don't go to the emergency department, they can get quite ill. Sick day management, of course. And then if we look at the NHS data that recently came out, the relative risk of death and the hazard ratios were lowest for people with an A1C of 6.5 to 7.5% with a normal BMI. Next slide, Nick. And then what travel precautions should people with diabetes take? Next slide. These are, there is no evidence to help us give a better answer for people with diabetes, but the ultimate answer is staying home is the best way to protect yourself and others from getting sick. So if you can avoid travel, do avoid travel. If you must travel, bring enough supplies with you. And there are specific contingencies depending on what mode of travel that you are taking.